GLP-1 medications have effects in your body that kind of make you kind of stay away from food, right? You look at it and you go, this is fuel. Do I need this? Do I not? Right? From a mental perspective, there are companies out there trying to come up with ingredients that will bypass those medications.
3, 2, 1, let's go!
We are here with Dr. Joseph Melendez-Davidson from the Memorial Bariatric Group. He is a bariatric surgeon, an expert, fellowship trained, board certified. He is local here in Broward County, and we are talking all about the different things that are going to help you change your life, from losing weight, whether it's taking a GLP-1 inhibitor, which is very popular right now, like Ozempic. Obviously, you got to speak to a doctor about it. Also, we talk about changing diet and improving your life. This is going to be fantastic.
Eric, thank you very much for having me here today. It's always a pleasure from knowing you from before, from our kids' school and activities and everything. So, like you said, I'm Dr. Melendez-Davidson. I am a board certified and fellowship trained minimally invasive and bariatric surgeon. I'm currently working out of the Memorial Health System. It's been my passion to do what I do for the past decade or so, a little bit over. I truly love helping patients out, giving them hope again, giving them that second chance in life that they need, that they deserve. And even if it's not a second chance, even if it's a third or a fourth, with my sets of skills to be able to allow them to have that life that they want. A little bit about what I do. I do what we call foregut surgery, which is surgeries of the upper gastrointestinal region. So that includes things like weight loss surgery. It includes anti-obesity surgery. It includes hernia repairs. It includes anti-reflux operations and gallbladders and things of that nature.
So, and I guess that's kind of maybe the explanation, but what is bariatric surgery?
Yeah, bariatric surgery is a field within the realm of general surgery that we dedicate ourselves into being able to provide an anatomical alternative for the patient to be able to lose weight, to be able to achieve weight loss and weight maintenance, which is the more important part. A lot of people talk about, well, I want to lose this amount of pounds, but they don't think about, well, it's not just losing it, it's also being able to keep it off.
Yeah, and I think the topic of like longevity has become like massive right now, and it's everywhere on Instagram and TikTok, and people are just trying to better themselves, live longer. How does like bariatric surgery, if they're going to be doing some kind of bypass or something to lose weight, how does that help them with moving forward in their life, like and living longer?
Oh, absolutely. So it has been proven, and talk about an interesting profession, right? The statisticians who actually sit down and look at these numbers and are able to calculate these things that haven't even happened. They're looking a little bit into the future. But it has been shown that on average, a patient that needs a procedure, that undergoes a bariatric procedure, is able to gain between 7 and 10 years of life, okay? And to me, even a year would be an amazing, already an amazing accomplishment. To be able to gain 7 to 10 years of life, I'm sure everybody would sign up for that. The way that it does that is by reducing the comorbidities. So everybody thinks that weight is a problem of, the patient doing something wrong or something going on with the diet, et cetera. But they don't realize that weight is just kind of the byproduct of a much larger problem that is going on, that is manifesting itself as weight. In reality, that weight is an increase in adipose or fatty tissue. And those tissues are the ones that are actually damaging the rest of their organs. So they're creating things like diabetes, high blood pressure, cholesterol issues, heart disease. I mean, you can name it. If you name a problem from your head to your toes, has an association with obesity, including cancers.
They say sugar is the new cigarette. Is that true? Like as far as like how dangerous sugar is to the human body?
Is worse. Sugar is worse, in my opinion. And don't get me wrong. I think number one thing that I tell patients is, do not smoke. Okay?
Yeah, of course, right.
I still say that because it's easily preventable. Okay. I think preventing sugars is a lot harder than preventing smoking. Okay. But when you look at, dollar for dollar, what do they affect? Sugar is up there. It's just like you're saying, is the new cigarette, right? And it all started back in the 1940s and 50s. They were trying to, General Mills, okay? Hopefully this doesn't get us in trouble, right? But
You're good, don't worry.
General Mills was trying to increase the sales of their products. And back then there were studies that showed that the heart would get clogged up with fat, right? So they said, well, wait a minute, our products don't have fat, our products are grains, right? And they sent all these researchers to study it out. And the researchers came out and said, well, yeah, it doesn't have fat, must be good for you, but wait a minute, these carbohydrates, your body turns them into sugars, and then sugars back into fats. You guys know that, right? Oh, no, let's just leave it at the beginning. It's good for your heart. So everybody from the 50s on forward, when the cardiac studies started getting done, started believing that cherries is good for your heart, that all these carbohydrates are not bad for you, when in reality it's almost the opposite. Our body has a very, unique ability to break down fats that are easily digestible, like animal and plants fats, and use it for its own, for its own advantage, versus complex carbohydrates and things like that, which your body will eventually turn into the bad fat that is going to kill us, right? So think about that, what sugar is really doing to your body. We worry about bacon, but we don't worry about cereal, right? We should be we're worrying about the wrong things sometimes.
And it's crazy because you can walk down the aisle of every single supermarket and it's just aisle after aisle. Well, I don't want to say aisle after aisle, but just all those different cereals. And then you think about what your kids are eating, and it kills me because it's hard to get them to eat healthy for them. We do our best, but think about it. It's like my son asks for a couple Oreos every single night. It's like pure sugar. You know what I mean? Yeah. They're not big into like the box of cereal. They eat kind of more like an oatmeal or but still it's in everything. Yeah. And it's very, very difficult to avoid, but it's having this really terrible impact because what you're saying is that the sugar converts now back into fat.
Into adipose tissue.
And then, but it's not the same kind of fat that you would get from like a meat or like cheese or some whole food.
Correct. It's highly processed carbohydrates. Mm-hmm.
So really those highly processed carbohydrates, are those like dramatically, I guess, having an impact on people's weight?
Absolutely. And we're seeing that. And just like you're saying, it's sugar. So it releases, certain things in your body, right? It releases that dopamine, like, oh my God, this is so good, just like a cigarette does. Or like, any other drug potentially would. And they've done studies about how much, the brain actually reacts to these compounds and sugar, fructose and all these syrups that are in everything that and a lot of things that we consume these days do release the same, endorphins in our brain of pleasure, right? So that's why our kids go, well, I want some more. Because if you really sit down and taste an Oreo for a while and you really try to taste the flavor, you're like, this doesn't really taste good, right? It's just all the sugar. So we're becoming addicted to it. Now, the kids, by a different mechanism, because they're growing and developing and everything, they can handle it better than you and I can. The problem is those patterns that we're establishing now and the quantities that they're being exposed to, right? So we're seeing a huge exponential growth on the rate of obesity of kids under the age of 17 in the United States. And it's increasing at alarming rates. And not only that, but unfortunately, we know that because they're at a young rate, right? So even though they're less prone to getting the effects, the medical problems, the diabetes, the blood pressure, et cetera, when they're young, because they're going to now become obese and suffer from obesity for a much longer time than somebody that develops it in their 30s or 40s, now that person is at risk of dying by about 20 years younger than a counterpart that doesn't suffer from obesity at that same age. So it's very interesting because even though they don't suffer from it right now, they are, us parents or, whoever it is, maybe putting their kids at a huge disadvantage later on in life.
And it's crazy because as you think that as time progresses, that with technology, the products become better, healthier, improved, right? But it's like the reverse with the high fructose corn syrup and these other additives and the other types of sugars that they have. Like you said, these kids are eating a whole new batch. They're almost like the guinea pig for these sugar companies. Correct. Of what's going to come. Correct.
Right? Correct. And it's sad to say because, when we look at this, you mentioned something, very interesting is the guinea pigs, right? Food producers, manufacturers are actually coming up with alternatives with compounds that are trying to undo what medicine in general is doing, okay? And is doing it on purpose, right? So I'm sure that everybody that's listening to this is probably aware of the GLP-1 medications, right? And GLP-1 medications have effects in your body that kind of make you kind of stay away from food, right? You look at it and you go, this is fuel. Do I need this? Do I not? Right? From a mental perspective, there are companies out there trying to come up with ingredients that will bypass those medications.
Wow, that's unbelievable. Yeah. That's like, I'm trying to think of
because
how
they've lost money.
Yeah,
right.
Yeah, because they're losing money, right? It's like this is so crazy when you think about how these companies that they produce whatever product is with all this sugar. It's so similar to what sounds like with the cigarette companies. The cigarette companies used to, they design their cigarettes to be highly addictive. They formulate it in a very specific way so that people are going to be able to easily inhale it. It gets to the brain, it gives them the dopamine hit, and they get addicted to it. And then you have companies like whatever it was, Merrill Dow, that came out with the chewing gum, right? Like Nicorette. Yeah. And the companies had to try to figure out a way kind of to get around it, right? Yeah. And now they probably have, right? If you think about it, is now these companies, instead of almost fighting the Nicorette gum, they've come out with products like Zyn or like some other tobacco that you can kind of put in your mouth and sit at work and you're having nicotine. Correct. But I guess people really can't underestimate what these companies are doing when you have pharmaceuticals that are coming out to try to help people lose weight, right? Correct.
When we think about obesity unfortunately is a problem that humanity created, right? When we think about way back, 50,000, 75,000 years ago, right? Your ancestors and mine were probably in different places, but they were cavemen and cavewomen, right? Yeah. And they were all in shape, and they were all, they had a shorter lifespan, but they did not suffer from a lot of the medical problems. And we have to wonder, well, what happened between that 50,000 years ago and today, right? So back then, the cavemen had to be hunting for food to be able to survive, right? So what did our bodies do? Our bodies develop a hormone that makes us hyper aware of food called ghrelin, right? Ghrelin, the majority of it lives in part of your stomach, and it gets released almost 24 hours a day, 7 days a week. And then once you found that big woolly mammoth or the berries in the forest, whatever it was, your body had to be able to fit a lot of that food so you would consume it, develop a very large stomach. Your stomach, mine, they can hold between 1.5 to 2 liters at any given time, a lot more than what we need, okay? And then we develop fat. Fat is nothing else other than grabbing all that energy, being able to store it. The problem is that, we're not hunters, right? We're not gatherers, we're consumers. We go to anywhere, McDonald's, every single corner, Starbucks, and, even the food that we consume from Whole Foods is not the same quality that it was 50,000 years ago. So we are putting poisons in our body, okay, as healthy as we wanted to think about it, but we are putting things that we're not meant to consume, or perhaps the quality is very, very poor. But yet we have a hormone telling us, you need more. Yeah. And we're being fed from other alternatives. We're being fed these types of food that hormone is actually looking for, food that is very high in calories, that is easily consumable, digestible, that turns them into adipose tissue. Because your body's in this state of like fight or flight, right? Well, I got to prepare for that rainy day. Problem is, we don't have a rainy day.
Wow, man. And you see this is like, because this is your career, you're on the forefront of it. Yeah. And are you working with patients just not only just doing the bariatric surgeries and things like that, because they've been exposed so badly to this new, relatively new lifestyle, but are there medications that you're using also to help patients and talk about the effectiveness of those medications? So
every patient that comes and, is looking for our help to navigate them through this, it's very important that we don't think of everybody as offering the same treatment for everybody, right? So we have to be doing a very individualized kind of decision algorithm within every patient. So we treat every patient as an individual. We're looking at things of, the pattern of obesity, the genetic history, what are the medical problems are affecting that person, the reason, that led them to the way that they are today, right? And you have a big gamut of things, from emotional issues to behavioral components to addictive personalities to actual diet issues, less exercise, injuries, etc. Once we identify what those issues are, we try to individualize a plan for that patient. And that can go anywhere between diet, exercise, nutritional coaching, right, all the way up to very complex surgeries or medications that are somewhere in the middle. What we know is that the medications that exist today perhaps have been some of the best medications to ever exist in the market, but they're not foolproof. They're not a magic wand that everybody can just use and everybody will attain the results that they see with the Kardashians, like we were talking earlier, right? Still to this date, surgery is thought to be the number one way of not just losing the weight, but also keeping it off in the long term, which is a little bit different than medication. So you're going to be surprised at this number. I think we all like to think that we try to be as healthy and as active as possible. But if I was going to tell you that people who suffer from morbid obesity, who try diet and exercise alone, to be able to lose the weight and keep the weight off, how many of them would you say are successful?
I'm going to guess only because I think it's very similar to like cigarette smoking, people who try to quit, but I'd say 5% or less.
Yeah, it's 1%.
1%. Wow.
1%.
Wow.
1% of people are the ones who are able to lose the weight and keep it off for more than a year, right? So we're just cutting it short at a year. When you look at some of the medications that have existed in the market before the GLP-1s, which is what we're getting ready to talk about in a second, when you looked at those, you were able to say, okay, maybe 18, 20%, okay? Old medications, right? Like the fen-phen and, Adipex, those kinds of medications. Now, when you're looking at the GLP-1 medications, which is a very interesting subset or subgroup of medications, because these medications, what they're trying to do is to mimic what surgeries have been doing for decades, okay? They're not quite at the same level, but that's what they're trying to do. So GLP-1 GLP-1 medications are agonists of GLP-1s, which are a receptor that we have in our own bodies. And that receptor, what allows your body to do is to release insulin only when you need it. So it's glucose dependent. So meaning you consume glucose, your body needs insulin to break down that glucose, then that receptor will help you to do that. Versus somebody who, for example, is a diabetic that may not have insulin, may not have enough of it, or may have lower sensitivity to it. So when people take that medication, how many of them are successful at losing it and keeping it off? Anywhere between about 20 to 30 something percent, okay? Still not a great number. Okay?
That's with Ozempic. Okay.
That's those things are like Ozempic and Wegovy, which are actually the same medication, just for two different reasons being used. That's what I call first generation or 1.5. Generation 2, in my opinion, that's Mounjaro and Zepbound, which are dual agonists. So those are medications that have two different peptides, okay, including GLP-1 and glucagon. And then there's newer medications that we were discussing a little bit earlier, like retatrutide. Oh my God, that's a mouthful. Those are coming up soon. Those are going to be triple agonist compounds. That one, again, not out yet. So the medications are better than any medication that's been on the market before. Still falls short, unfortunately, for a lot of the patients that we treat, because if somebody needs to lose anywhere between 20, 30, maybe up to about 40 pounds, medications, 100%, no question about it. They'll allow you to do that. Now, keep in mind that once you stop the medication, the weight tends to come back up.
20 to 30%, or we said what? 20 to 30%,
20 to 30%
or 30% of people are going to succeed. Yeah,
they're going to succeed. Once you stop it, the other 2/3 of it essentially will fail. Okay. So again, better than any medication, better than diet and exercise alone, but we still encourage diet and exercise and good nutrition, of course. Now, when you're looking at surgery, it changes things a little bit. Depending on the operation, it can be anywhere between upper 60s to low 80s, 80%. Still not perfect. But when you compare the numbers, you can see really where the big difference is. Success rates are much higher with surgery, not just at keeping the weight off over a year, but keeping the weight off for at least 5 years is where we do the data.
And when we're talking about people that are getting the surgery, are we like, is there a weight like a weight group that you're looking at? Because you wouldn't want to be 250 pounds and say, let's do gastric bypass surgery, or maybe you would, I don't know.
So, Chris, so what we base ourselves of is off a number that I don't like myself. Okay, it's called the body mass index, which is a ratio between your height and your weight. It's a heavily flawed number, but guess what? Insurances go based off of that.
Okay.
So we're trying to make a quick determination. Are you too heavy for your height? But you can see how that becomes a problem, because if you're an athlete, if you're a bodybuilder, you're going to be heavier than the average Joe, right? So we try to use a little bit of caution with that. The weight must come in its majority from adipose or fatty tissue. So based on those categories, we'll calculate something called the body mass index. For surgery, anyone who has medical problems and has a body mass index greater than 35 should be a candidate for a surgery. For people who do not have medical issues, right, they have to have a body mass index that is greater than 40. Now, there's been some studies that suggest even lower, down to the 30s. When we talk about medication, then we're thinking about the opposite range, right? So anywhere between the body mass index top limit of 35, bottom limit of about 25. So 25 to 29 is what we consider overweight. Those are the vanity pounds, the ones that have not been shown to establish any true medical issues or anything like that, but that you still should come down. So anywhere between 25 to 29, that patient should be a candidate for medications. Not by insurance, just by medical kind of knowledge. When you think about insurances are almost always going to say no to medications coverage because of the cost.
Is there a combination effect that you see with your patients, where if you have someone that they're the candidate for surgery, you do the surgery, and then you you combine it with the medication, or is that not something you do?
Absolutely. We do that on a select number of patients, and we do it for different reasons. Sometimes patients are, and not patients, but their bodies may be a little resistant to change, right? And we need to give them a little bit more, right? So we tend to use it sometimes when patients are like full-blown, what we call intractable diabetics, right? They're diabetics that are very difficult to control. These medications are amazing for diabetes, 100%. So we may use it in combination with surgery to really decrease those levels of hemoglobin A1C and get them to a better state. Or we may also use it in case we see a patient that has had surgery and now they're stalling for an unknown reason. We're going to give them a little bit of a jump start. Interestingly enough, what we have found is that you're not just adding weight loss. When you combine them, you're actually amplifying the weight loss of both the medication and the surgery. Quick example: if you're going to lose 5 pounds with surgery and 2 with medication, you're like, I'm going to add them both, and I'm going to lose 7. No, you lose 10. Okay.
You lose 10, yeah.
So it's synergistic.
A synergistic effect.
A synergistic effect, which is very interesting.
Man, that's so interesting. Do you see generally, like if like when someone is obese, patient comes with obesity, is there typically a correlation or that they also have diabetes?
So yes, diabetes type 2. So it tends to be that diabetes type 2, suffering from obesity predisposes you and unfortunately puts you at a higher risk of developing type 2 diabetes. And there's some other diseases as well, such as polycystic ovarian syndrome in females, right? Those 3 have a very big correlation between them. Versus type 1 diabetes, which produces no insulin. People are usually very thin. So when we're talking about type 2 diabetes and obesity, there's a very strong correlation. Interestingly enough, people who undergo weight loss surgery, 83% of them are cured from their diabetes.
Wow. It's crazy because I had my blood done, and like you talk about this, like what's in the food that we're eating and everything that we're doing. I mean, I had my blood taken, I think earlier this year. My A1C was above the normal range, and it was, they said this is like I don't know if they said that you're at risk or you are at the point where you're like, this is almost considered this is almost considered diabetes. You know what I mean? And I was blown away because generally I thought I'm in decent health. I work out all the time. But at the time, my diet was probably eating pizza, sure. Throwing just, if I throw Chick-fil-A in there or you have a McDonald's every so often. But I'm seeing these numbers and I'm like, man, I feel healthy. I feel good generally, but like what's happening, And so I just decided I'm going to make a change and change my diet and kind of cut out the carbs and the sugar. And redid my blood test a couple of times and watched it drop down. Watched it visually go from whatever it was, like 5.7 down to like 5.3 or something like that, which to me was great.
And with diet.
Yeah. With diet, yeah. What are the the 2 or 3 things that you tell patients? Let's exclude medication and surgery to help them lose weight, get into better shape.
Say it one more time.
Sorry, yeah. What are 3 tips that you give to your patients to lose weight? And we're not talking about the medication, and we're not talking about surgery. Got it.
So one of the main tips that I give them, number 1, cut the empty calories. Okay. So those are the calories that we don't even think about, right? And mainly they tend to come out of liquids, right? The soda, the orange juice in the morning, the little bit of sugar on the coffee. Those sugars start adding up throughout the day. Okay. That would be the number 1, first and foremost. Second, eat your proteins first, right? So proteins, they can make you gain a little bit of weight, but the weight technically is going to be muscle mass for most people, right? And muscle eats fat, okay? So eat your proteins first. If you're still hungry after the protein, then eat your carbohydrates, okay? And the third thing is increase your physical activity. So even though physical activity is not going to get you to have a massive weight loss, it'll definitely help you maintain that weight loss. So again, is no empty calories, mainly coming from liquids. Increasing the physical activity and eating more proteins and less carbohydrates.
Wow. And when you say, this is interesting because when you say eat your proteins first, are we talking like generally, like if this was a tip for people, like if you're sitting down, you're going to have dinner, are we talking about like on that micro level where like eat the steak first and then go ahead and have some potato after?
Yep. Exactly.
Why is that?
Exactly. Because if we, if we start with the potatoes, right? Think about when we go to a restaurant, what do we start with? The bread.
bread, yeah,
right?
of course.
And by the time the steak, which is what our bodies really need, building blocks, right? The protein in our body. By the time the steak comes in, what are we taking home? The steak, right? So if we push the bread away, right? Okay, you have a little tiny bit of salad, but then the steak comes over, you eat the majority of the steak. And if you go, okay, I just want to see what the potatoes feel like and grab a little bite or two, at least just to get it out of your system, right? Now you didn't eat just the bread and the potatoes and the whatever, but you did eat most of the steak, which is really what your body's craving for. So I think we got it completely mixed around. Look, I didn't say this at the beginning. I'm Latin. I look like this, but I'm not American. I'm from Puerto Rico, and I know how our diet is. We have a diet that is very, very heavy in starches. Okay, is rice, is beans, is tostones, fried plantains, right? And then the pork on the side, and probably a little piece of yuca with it, right? So think about all that. I just mentioned one protein, like 5 different carbohydrates in there, plus your little piece of bread, et cetera, et cetera. So for whatever reason it is, whether it's cultural or environmentally learned, we definitely consume too many carbohydrates, and maybe this is a learned behavior, maybe it's cultural, but I think there's a big rebalancing that we need to do based off of that.
Yeah, and I mean, listen, getting this information out to people too. I mean, I think it's something that you hear often. Like I've always known, or I haven't always known. I think I read a book a couple years ago, and it was like cut the rice, cut potatoes, don't eat banana, like the high sugar fruits like bananas, or there's a lot of sugar in there. It converts, When you cut that out and you focus on protein and vegetables and fiber, right? You're gonna drop weight. You're gonna start losing weight, and you're gonna feel better too.
Absolutely.
I feel so much better right now than I did like 3 or 4 months ago when I was eating. Again, this is Chick-fil-A is so good, but that they are literally. I think they're making it chemically addictive. Okay, they're doing something, man.
They're absolutely. They're all doing something. They're all doing something.
All right, so those are the few tips. I like that. Thinking about just it's those little empty things too. They add up. They can't.
It's empty. Is a little cup of ice cream right before bed. It's the little things that we say. I've been good today. Let me treat myself.
My weakness right now is like I have a half a bag of popcorn. Probably at 7:15 or so.
Okay,
I throw it in the microwave, have half the bag.
That's not too bad.
But that's after dinner, But I don't know that I can give it up.
That's not horrible, right? I always tell my patients to do not kill yourself for this, because the point that somebody starts seeing it as a burden on them, they're going to quit. This is why diet exercise in the long run doesn't just work. I mean, it works for the guy who's always been that way, right? But for the person that has never done it, and you're trying to inflict this on them, they see it as a punishment. Where if you try to change the mindset of the patient and saying, hey, listen, let's think about your lifestyle. Let's change little things at a time. Let's change this. And look, this thing, instead of eating it at 7:00 p.m., let's move it to noon. You can still have it, but let's just not eat it there.
Yeah.
I think that starts changing the way that we think, right? And we have to start thinking more as food being a fuel for our bodies and what we're trying to accomplish, rather than saying, food is comfort, because food is comforting, but we shouldn't use it for comfort. When we're eating our emotions away a lot of the times, and that's what damages us.
Oh yeah, forget it. It's like, and then if you don't eat like all morning or something like that, and like you're stressed out and like you get starving because you didn't eat your breakfast, you're trying to, be healthy, or you're doing this intermittent fasting, then it's like, 1 p.m. rolls around, you see a Burger King, and it's like you got to crush a burger, and that's not healthy,
No, and think about, what we talked about earlier, what ghrelin is doing. Ghrelin is still sending your brain messages saying, I'm hungry, feed me, I'm hungry, feed me. You just learn how to control it consciously, but in the subconscious, it's still producing anxiety and stress. So sometimes you hear, people saying, oh, I didn't eat it, my husband ate it, but I gained the weight. Yeah, there's some reality to that, right? There's all this stress that gets built up. They're on a diet. They're looking at somebody else eating. They release cortisol. Cortisol retains water. They start gaining weight. And these are the things that people don't realize that they cannot change, right? You can change your exercise. You can change your eating habits, but you can't change your genetics, okay? You cannot change your metabolism. We can do it medically for you, okay? But it requires a lot of commitment. There's no question about that.
Yeah. Give me just the broad explanation, or at least describe how this Ozempic medication, like how it's working, and why are people losing so much weight taking it?
Yeah. So the GLP-1 medications are an agonist of a naturally occurring peptide or hormone, if you want to think about it that way, in our bodies, right? GLP stands for glucagon-like peptide, number one. There's several of them. So there's a little receptor that makes our body release insulin when we consume glucose, right? That's how our body should function. The problem is there's so much glucose in our diet that our body dysregulates, sends insulin. Sometimes it doesn't. Sometimes it becomes resistant. That's how diabetes type 2 happens. So these medications, what they do is they're an agonist for that peptide, and they allow your body to release the insulin only when it's needed. So if your body releases insulin when it's needed, it's able to, digest that sugar a little bit better. That's one of the effects that it does. So that's how it controls your hemoglobin A1C levels. So it controls the diabetes, it controls the glucose levels in the body, and it controls weight up to a certain level. The other thing that it does is it slows down the stomach. Now, I got patients telling me sometimes, look, I heard that this medication causes gastroparesis. Well, yeah, it does. That's how it works. But I don't want that. Well, that's how it works. Gastroparesis means that your stomach doesn't empty fast enough or well enough. Earlier, we mentioned that the stomach can, hold between 1.5 to 2 liters of food, but that's not what it's always holding. You have a meal, usually within an hour, that food is out of your stomach already. In patients that take these medications, the food can sit there for 4 or 6 hours. Now imagine you feeling full for 4 or 6 hours. You go, I just don't want food, leave it alone. That's how the weight loss starts happening, okay? The problem is that only works while the medication is in your body. And not only that, but your body is also becoming kind of accustomed to it or, used to it. So you have to start increasing the doses little by little. And there's going to be a plateau effect when your body says, okay, I can function, I can still control the glucose, but I'm not going to give you that weight loss anymore because, it is what it is. You've already kind of reached that. But the medications, no question about it, are a good alternative for the patients that either are not a surgical candidate or for patients that do not need to lose too much weight, but still need to lose some weight.
How important it is for people that are taking Ozempic or these GLP-1s or any of these other weight loss medication to be monitored by a doctor, so that you're tracking them, you're watching the progress. How important is that?
It's extremely important, in my opinion, and I get it. I may be biased coming from where I come from, but the reason why I say that is because it's twofold. These medications are a huge opportunity for people who do not have the experience to make a lot of money. Let's face it, right? And for different reasons, right? The way that they manage the market, the way they manage the medications, the supply, the demand, the access to the medication. The problem arises from the fact that insurances are not covering most of these, right? So people have to resort to other means. I get it, 100% get it. The problem is when someone who only understands the very minimum now has the power to prescribe these medications without knowing what they're doing, okay? They may be doing it legally or illegally, but the fact is that they don't know what they're doing. So these medications are not as easy as saying, oh, somebody I read on the internet that is 2.5 and then 5 and then 7.5 and then I go up and no, it's not as easy. You have to monitor what the body is doing. You have to see who is a good candidate for medications, who is not, who is exhibiting early side effects versus who's tolerating the medication well. These medications are not only are they not just foolproof, but they have a lot of potential for harm if not used appropriately. And we have seen harm even in patients that have used them appropriately by persons that know what they're doing. So it's extremely important to have someone that will be able to look at you in the face and say, I know this is going to cost me, money right now, but you're not a good candidate for this medication. I cannot prescribe you this because it's not going to do you good. Versus going somewhere that's just going to give you what you want. Let's face it, the reality is the majority of people out there, they just want what they want when they want it. When you have these medications being prescribed by somebody who knows what they're doing, whether it's a bariatric surgeon like we are, or a medical bariatrician, or an endocrinologist, these folks have had extra experience, extra training into knowing what these medications do, who is a candidate, who is not, how to monitor these medications for success and for failure, and knowing when to stop and how to stop.
I mean, these are like, truthfully, like people need to realize these are powerful medications. Like you are putting something into your body that's actually changing the way you operate. And you talk about it literally is stopping your stomach from, digesting or however it works. It's like, and not emptying out your stomach, what I mean? And it's staying in there for a certain amount of time. That's like, it's critically important to see a doctor that's qualified, that knows what they're doing.
Correct.
you know. Let me step back a little bit because I want to talk about your career and how you became a doctor. And I know you went to medical school, I think, in Puerto Rico. So tell me, tell me give me a thumbnail sketch about medical school. How hard is it for a student that's looking to go to medical school right now? They want to go into it. Like, just tell me, like, what do they have to look forward to and how hard they have to work?
Yeah. So I think knowing early and preparing early is the best advice that I can give anybody from when they're in high school, or perhaps your son, my son's age, okay? Which is something that I didn't have before, okay? I'll tell you that my career into medicine was not a straight shot like most physicians tend to be. Originally, I actually wanted to be a test pilot in the Air Force. I went to the Air Force Academy, and I was pursuing a completely different career in that sense. It's interesting how life changes and the path that you take, it changes you, but to go from an aeronautical engineering major, all the way, and then all of a sudden going, you know what, maybe so-and-so was right. Maybe I should study medicine. And then trying to backtrack and do all that and still graduate in time, didn't cost me any time, but it definitely cost me a lot of hard work and effort. So any student out there that is thinking about a medical career, the earlier they get involved, the earlier they get exposure, I think the better is going to be for them to open up that field of view and saying, hey, listen, this is something that I see myself going through or not. So you go to college, of course. During college, you start applying for medical school. Once you get accepted to medical school, then that's really when the fun starts, okay? So medical school is another 4 years, but it's not the end of it. It's not that you're just like, okay, I'm a doctor and that's it. No, there's several tests you have to take, and there's an attrition rate within those tests. So, people that you start with is not the same people that you're finishing with. Yeah. So it's definitely an arduous process. And if you think medical school is tough, that's nothing compared to residency, which is the next step. So while you're in medical school, you're just learning the basics, right? You're learning the basics of anatomy, physiology, pharmacology, and starting to gain a little bit of that clinical aspect of, well, how does, medicine really work in the real world, right? But once you're almost done, now is a turn to, take some more tests, of course, see how well you did, and start applying to different specialties. And in the world of medicine, I mean, all of you out there can think about, how many different specialties there are. And of course, there's a ranking of those specialties. Which specialties are easier, which specialties are harder to get into, which ones are more demanding, and which ones are less demanding. And, it's to everybody, to each his own, right? You have to find what you love and what you don't like, and do not do what you like, right? But eventually that becomes another hurdle because not everybody gets into the specialty that they want or that they're shooting for, right? So it's very important in medical school to really prepare yourself, to do research, to really strive to get a lot of experience within the specialty you want to go into to make sure that that's the right fit for you. Once you do that and you apply for residency and hopefully you get into residency, now it depends on the specialty, right? And the specialty can be anywhere between about 2-3 years all the way up to 7-9 years in some cases of extra training that comes after medical school. That's the tough part, okay? I think everybody would agree, all the medical professionals out there would agree that residency was probably one of the toughest things they've had to do in their lives because of the time commitments that come with it, the amount of learning that you're doing, the amounts of times that you get things wrong and you feel horrible because of the mistakes that you made. But thankfully, there was somebody ahead of you that caught that mistake and saved you from it. But nonetheless, those things are the things that you really learn from. And that goes on for a very long period of time. So, my number one thing that I got to tell patients, or not patients, but, aspiring students is to never give up, to not let a little mistake or a little downfall or, a little bad day kind of, take over them. Just keep fighting. Don't let anybody, tell you otherwise either. Just keep fighting for what you want.
If someone's in medical school now, and you say it's 4 years, like when should they really start to consider the area that they like really want to focus on as far as the specialty? Is that first year? Is it second year?
I would say right around the second year, between second and third year. And it may be a little early for the majority of students out there, but I would say that between second and third year is at least where you should start saying, okay, look, more or less, these are the things that I like and the things that I don't like. Doesn't mean that you have to hone in on something. But just have a little bit of a general perspective of, look, do you want to be in the surgical area? Do you want to be in the diagnostic area? Do you want to be a proceduralist? Do you want to be an office person? At least have a general sense of what you like and what you don't like. Doesn't mean that, okay, I'm going to be, a surgeon of the right leg and only of the fourth toe, right? But at least have a little bit of a general impression of what you want to do. By the time that you're in your fourth year, you should definitely have a good sight of what you want to do.
I would think that, like, at least with a lot of the students that go to medical school, they would know right away whether they want to go down like a surgical track or whether they want to go to like internal medicine or family medicine. You would think that. Maybe I'm wrong, like maybe second year, because like you're kind of going into it being like, I don't really want to cut, I don't want to be doing the dissecting.
Yeah, so it's interesting because, you have some people that are like that, I can tell you I have a friend who's a 6th or 7th generation gynecologist.
Uh-huh.
I mean, think about that, right? Like you're born and everybody's going, you're going to be a gynecologist, right? So this kid knew exactly what he was going to do. And then you have folks that have never had experience or, any insight into what is medicine. And that's the exploration, right? Those are the ones that perhaps may take them a little bit longer to kind of realize, okay, well, what exactly is it that I want to do? And you have people that change their mind very last minute. I had a classmate that we all thought she was going into orthopedics. Brightest person in the class. Got interviews and everything. Last minute goes, not for me.
What'd she end up doing?
I want to say it was emergency medicine. So still in that field, but definitely a different degree than what it was going to be.
I think it's for the most part probably similar as law students, because like when I went to law school, it was like when I got there, I had no idea anything about law. Like I didn't know what, whether it's criminal law or whether it's contract law or whether you're going to be a personal injury or probate law. Like you just had no concept of what any of it was until you start to read each subject. And then you kind of have to say like, oh, well, that is appealing to me, right? Like criminal procedure is one of the most exciting areas. I just didn't want to become a criminal defense lawyer. You know what I mean? And I think that's for a lot of people. Like it wasn't like personal injury law was not on my radar until I worked for a big law firm or, that did defense work and did international law. And I was like, I can't stand this. And then you read a book about personal injury lawyer and you're like, that's who I want to be. I want to be the trial lawyer in the courtroom. And then you can kind of navigate and focus your energy towards that. I mean, when was it that you figured out bariatric surgery?
Bariatric surgery in particular?
Yeah.
It was not until about my third year already of residency, fourth year.
So let me stop you just before we get there. Like when you did your residency, were you doing a surgical residency?
Correct.
So then when was it that you decided surgery, but and it was probably just broad general surgery?
Sure. So taking a step back, right? So I went to medical school and very early in medical school. And I think this goes back to the fact that I wanted to be a test pilot for the Air Force. I said, I'm going to go into the medical field, but if I'm not in the surgical field, I don't want to be a doctor. Okay.
Oh, really?
So I knew that it was going to be something procedural, something cutting, let's put it that way. Okay. Helping people out that way, something involving my hands, doing something. As far as then from there going into general surgery and everything else. So during medical school itself, I saw that by going to general surgery, I would have a lot more doors open to see where, what area of specialized surgery I would like, right? You can go from general surgery to cardiothoracic. You can go from general surgery to GI to colorectal. So there's a lot of different avenues of plastic surgery and trauma, et cetera. So at some point I'm thinking my top two choices are going to be either plastics or trauma. Okay. And I'm doing some rotations. And one of the trauma surgeons was also one of the starting folks in bariatric surgery. And I would see that he would do trauma as trauma, but his real passion was bariatrics. So I started rotating with this mentor. And he was showing me, he's like, yeah, I do trauma because it's kind of what pays my bills right now and everything. This is years ago, right?
Yeah.
But my true passion is being able to help these patients out. Look, I operate on this one. Has already lost 100 pounds. And to see the joy and the gratitude of patients coming to his office saying, thank you, you saved my life, their family, their kids saying, Dad can run with me again, et cetera. I said, yeah, forget about trauma. This is what I'm doing. This is what I really like. And forget about plastic surgery. I mean, I have a lot of friends that are great plastic surgeons, but this is what I want to do. I want to do something medical that I'm returning the life to these patients.
That's awesome. I mean, that's a really great story, because you think all medicine, you're helping people, right? You're changing lives, you're getting them better. But you found this one area that was like a niche practice, right? And like, yeah, you could go into plastics and probably make just, your Dr. Hochstein in the big building, and run it, you know what I mean, on whatever, you know what I mean? But you chose something that it's like, you got to find the passion, right? Sure. You got to find something. And then it's like you said, it's like so rewarding for these people to come in and you're able to see how you really, truly change their lives, like dramatically, Yeah.
If you think about, the field of surgery, and I've only been able to come up with two things, right? How often is it that you can have somebody willing to come into an office and saying, I want surgery?
Yeah.
Most of the time it's like, oh my God, so you're giving me surgery.
Yeah.
Oh, this is horrible. Why do I need this, right? It's usually only plastics and weight loss surgery. Right?
Wow.
People come into you and go, no, please. I want you to operate on me. This is what I want. And to me, not having to give bad news and coerce a patient to like, oh, you need to, it's actually very rewarding that somebody is looking to improve their life. They're coming to me and I can do something, not just to improve their aesthetics and their looks, because yes, that's going to come, but also to improve their health, buy years of life, buy them quality of life, and in return, get their family, even a better family member. To me, that's very rewarding.
Yeah, it's interesting that really, you like, because you've thought about this. I've never thought about this before. It's like most people, 99% of people who are going to get surgery, it's not because they want it. It's because something happened. They need to, right? Yeah. And then you narrow it down. It's plastic surgery and bariatric surgery. Yeah. And then if you think, when you narrow it down even further, plastic surgery is not going to like make them live longer, right? I mean, unless there's something there,
reconstructives, perhaps, things like that.
Yeah,
but not the typical what we think.
It's going to make them feel better. I'm sure like there's a number of different things, like you said, reconstructive, that's going to make them feel better, better self-image. And then you have yours where the surgery that you're actually doing is actually helping them with their internal health, their blood levels, their A1C, their diabetes, their obesity, everything. Yeah. That's really, really interesting. I never thought of it that way. What is residency? What does that look like for a someone who's finishing up medical school? What do they have to look forward to for, was it 4 years of residency or 3?
So residency is 5 years plus an extra year of fellowship in my case. I did 5 years in general surgery, and then an extra year in MIS and bariatric surgery. So that's a total of 6 years after medical school. What does it look like? They want us to, laws have changed a little bit, but the typical scenario right now is that you're not working over 80 hours a week. When I went through it, that was not a reality. Yeah. You work more than that. But it's for a reason. You're learning. You only have a limited amount of time to gain all this knowledge and all these skills. And you just have to cram up as much as possible within the first 5 years. So a lot of, missed family events, a lot of, sleepless nights or days. So it's hard. It's definitely one of the hardest things that I've had to do. Jude, my son, asked me the other day, he said, Dad, what's the hardest things you've had to do? I did survival training in the Air Force. Yeah. And I think I told him survival training. And then later on I was thinking it was 5 years of residency. 5 years of residency for sure. So it's definitely one of the toughest things there is, but it's doable. It's doable. If you have the right passion for it, if you know that you're not giving up, you can get through anything.
Is it every single doctor, they do the 4 years? And I'm just saying, like let's say narrowed to United States, are there residencies that are shorter for other areas? And what's like the shortest residency?
So the shortest residency out there, I believe, is about 2 years. Uh-huh. Okay. The longest one, if there's a residency out there that is asking for research within the residency, it can be between 7 and 9 years just for the residency.
Wow. Yeah. So you did 5 years of residency.
5 years, one of the longer ones already. Yep.
Yeah.
So if you think about internal medicine, for example, so medical doctors, that residency tends to be, I hope I'm not mistaken because things have changed, but it's usually about 3 years to become internist, internal medical doctor. If they want to specialize from there, if they want to do cardiology, if they want to do pulmonary, renal, then maybe another 2 to 3 added years to that. Okay. For surgical specialties, a little bit different because it depends on the surgical specialty they're trying to go into. But on average, the surgical specialties are about 5 years. And then if they want to subspecialize, then they need another extra year or 2.
Are all the residencies done at a hospital-based location? Like you have to be in a hospital to do the residency, or can you work out of a doctor's office? Like the way I picture a resident is you're in some institution, you're there all the time and you're learning from.
You're living there.
You're
called
living
resident.
There. You're a resident, right? Yeah, yeah.
So essentially, the majority of them are at larger institutions. There's a few of them that are more kind of clinic based or private based for different specialties, but the surgical ones are hospital based for sure.
And that's because that's where the most influx of patients are coming in, and you're able to work. And so is there like, you know, you may become, I think you were chief resident at one of the places, was it Alabama, I think?
In Alabama.
So you become, at some point you become chief resident, you've been living there, you've risen through the ranks, you've been working these 80, 90 hours a week. Who is it that you're like learning from? Is there like a more senior doctor, someone that is kind of guiding you and kind of overseeing what you're doing?
You learn from everyone. So at least that was my perspective. You know, some people see it as that way, like I'm just going to learn from doctors, and I get it. We're learning the most from doctors, but I'm learning even from, you know, the person who's coming in to clean the room, how's they're trying to treat that patient. I'm learning from the nurse, you know, how is she drawing the labs, right? How is she checking these vitals? So if you have a good attitude, you learn from every single person that you come into contact with, you know, from the person who is the family member and what are they saying, because the patient may be too sick to realize what their symptoms are and the family member is giving you the symptoms, right? But when you think about the hierarchy, which I think is really where you were coming from.
Yeah.
Yes, you start as an intern. Okay. So for surgery, you have a first year, a second year, a third year, a fourth year, a fifth year, and then you have your attendings. Within the attendings, there's even a little bit of a hierarchy. There's your junior attendings, there's your senior attendings. Somewhere in between the attendings and the residents are the fellows. So the fellows are the ones that are doing the subspecialty, right? So they're already a physician, full blown and everything, but they're trying to gain even a little bit more specialty. Even within the attendings, you'll find out, you know, that the whole senior versus junior, does it really mean much? Well, you know, the senior guy has been around for longest. Does not necessarily mean that they know more than the younger guy that is out there. Maybe technology has changed, techniques, things have changed, right? But you're learning from every single one different things. And I think the neat thing about this is that you're not just learning from one person, at least how I did my residency. You're learning from multiple aspects, multiple places. You're doing rotations. You're going along and, you know, 6 weeks or 2 months, you're doing this. And then the other 8 months or the other 8 weeks, you're doing something else. You're learning from different people. You're learning what you like and what you don't like.
Yeah.
So one of my big things is, you know, I'm never going to criticize what I'm learning right now. Later on, I'm going to grab from each person what I like, and that's who I'm going to become. And what I didn't like, I'm going to make sure I don't repeat those behaviors, right? So technically, you're learning from, you know, several dozens of people, if not hundreds of people throughout that career of, you know, your 5-6 years, and molding into who you eventually become, who you want to become.
You know, it's so funny. I'm glad that you threw that out there, that, you know, obviously you're learning from all these people, and you learn from the nurses, you learn from the nurse practitioners, you learn from everybody. But it's interesting because you talked about that you're this fifth year senior, you're the chief resident, but then there's another person, which is what you did, is they go to a fellowship, right? And they're the next level, and they're not even an attending physician yet.
Correct.
You know, so what is the fellowship?
So fellowship is, you know, you've already done your training, so you already are a surgeon, and now somebody's trying to teach you yet another set of skills. So I'll give you the example of my fellowship. I'm sure everybody has a little bit of a different example. When I went from UAB to Cleveland Clinic, I was already doing cases by myself, operating by myself. The attending at that point will call me and tell me, you do this, call me back if you have an issue, or call me back when you're done so I know we're done. Okay, so that was my last year, right? Going into fellowship, the first thing that Raul Rosenthal out there, in case he's watching this, which I love this guy, he says, forget that you're a surgeon. You're nobody here. I'm going to take away everything bad that you've learned. I'm going to give you everything new that you need to know. And for the first couple of months, he just had him watch them over and over and over again. So this is now where your skills get really honed. They get really specialized, right? Where he's going, look, this is a hiatal hernia, an operation for reflux. And sure, you know how to do it, but can you do it with your eyes closed? Can you do it without talking about it? Can you do it without thinking about it? Can you do it so precise that you can repeat it 100 times and you will not be able to tell the difference between one and the other? That's what fellowship gets you. So it gets you to really, you know, polish what you have gained throughout those 5 years in a very small particular area, of course, because you're not you're not going to be polished in everything. So in that particular, area that you've chosen, it gets you very, very well polished that you can say, well, not only do I have a specialty, but I'm an expert at this. And how many experts are there out there regarding this? Not a lot in the greater scope of things.
When you talk about it, like to me, it's like the life of a doctor of like the young, they're going to college, then they're in their residency, then they're doing the fellowship, and it's an adventure. I mean, that sounds to me like, at least whoever's watching and you're interested in medical school, like first you got to have the passion for it.
Absolutely.
But you're going to live a life of adventure because there's going to be so many different cases, so many different things that are going to happen. It's going to be like, and it almost reminds me of practicing law, of being a law student. Like there is this adventure. It is a grind. It is hard. You need to learn everything. And then there's some people, which is law school is unique, is you can graduate from law school and you can open up your own shop right away. You just become a lawyer and you've never gotten mentorship. I don't know how successful that is, right?
Correct.
Or you can take the option of doing something similar to a doctor where you do like the residency of law, which is like going to the state attorney's office, going to the public defender's office, where you're going to be working on case after case after case as a young lawyer, learning from other senior people, and you have that adventure. And then getting the mentorship, like at least I'm just thinking about like my own career, like going to the state attorney's office, doing that grind, like, whatever it was, 60, 70, it wasn't, 90 hours a week, but that was a lot. But then getting a job at like a law firm as a young associate and watching like the senior people, just watch, you know what I mean? Like you don't have to get on you've tried a bunch of cases, you've made mistakes. Now watch how it's done the right way. And learn and go to court and slowly just help out and be there and watch. And then all of a sudden you start to slowly get on your feet and start to do this one piece. And then you do the second piece and then you build upon it. And then you become the expert, Yeah. I think anyone, I encourage, I know there's a lot of people they discourage the youth from getting into these different careers. They say, like, don't go into becoming a doc, don't become a lawyer, go to finance, go to a hedge fund, make tons of money, whatever.
Yeah. Don't do it for the wrong reasons.
I encourage, I seriously, like, I gotta change that attitude, because sometimes I say, like, do you really want to be a lawyer? Like, you gotta encourage it, because if they really want to do it, it's a life of adventure.
Yeah. And I think going back to the financials, what you said, I think if your passion's in the right place, the money will become secondary. But the money, if you have a lot of passion, the money will likely come with it, because you are very good at what you do. And people are going to search you out because of that passion that you have. Versus somebody that is just doing it, I'm just going to do it for the money, then they're not going to have their passion, they're not going to have their heart. Yeah. People are not going to look for that business, right?
Yeah, so. I totally agree. And I think some people will criticize that statement sometimes, like, oh, you're always going to do it for the money. But like, when I went to the state attorney's office, it wasn't to make money. It was because I wanted to become a great trial lawyer and I wanted to get trial experience. And when I went to my first law firm as an associate, I was not getting paid well and I was working unbelievable hours, right? But like, when you have that excitement for it and you just have the passion and you're enjoying what you're doing and you get to be in court and you get to work with clients and you get to, change lives, like, the money will come. But it's a long game. It's not a short game. It's not like, everyone thinks they're going to get rich quick. It's not. And the younger generation needs to know that, like, building that career and building wealth over time, it takes time. It's not tomorrow. You know what I mean? You're going to hear about a couple lottery ticket people every so often, but it's not the norm. I think that's the unusual,
Absolutely.
How are you seeing? So you finish up the fellowship. Now you become the expert and you're working. That's when you get into private practice.
That's when you start realizing that you're not an expert yet.
That's great.
So you get into practicing, your surgical career, and you realize how much of the business of medicine you don't know. Because guess what? You've just focused the past 10, 11 years in medicine. How does the body work? Mind, body, etc. But nothing about business, nothing about cost, nothing about how to manage an office or, deal with hospital politics or anything like that. And that just comes little by little with experience. Now, these days is interesting because the the majority, I believe still to this day, the majority of physicians out there have become, like myself, have become in strong associations or owned by hospital health systems. And that has come up because of a multitude of issues, right? But it doesn't take away the responsibility of being able to know these things and to manage these things. So when it comes to being able to run your side, of medicine, yeah, you're an expert at medicine, but what do we do? What do you mean? How do I program my schedule? What are better days for the patients to come? And it's a learning process. And that's when you have to rely on people that, again, they know more than you, right? So you go and rely on, the office staff who perhaps this office has been running already for a couple of years and know a little bit, they have a little bit of experience on, hey, listen, the schedule when we do this, people tend to show up better, et cetera. You go to that senior partner who's already been practicing 5-10 years more than you have and goes, let me present you these folks in the hospital, and this is so and so, and this is da-da-da. So those social connections and everything are extremely important. So medical school, residency, fellowship makes you an expert in the clinical side. Does not make you an expert yet in medicine. So there's still a lot of learning that you have to go through, as you're going through.
It's so funny that you brought that up because I almost feel like our career is somewhat of a mirror. Yours is way cooler. You're just much more of a badass than I am. But the idea of exactly what you just said, I spent 11 years at a law firm, right? And I was the trial lawyer. I was the surgeon in the courtroom. I'm the technician doing all that. And then I left and opened up my own law firm in 2020. And it's whoa, wait a minute. There's an entire other side of being a business owner, an entrepreneur. How do you get the clients? How do you generate clients? How do you help how do you have office staff and this? And it's law school doesn't teach you that. And medical school probably didn't teach you that. And it's that would be good. That'd be great if there was somewhere where people, and I think now at this point, we have, mastermind groups and lots of other organizations that do help with the business side of law. I wonder if it's similar, if in medicine that there should be, and if there aren't, it sounds like an area we're going to start a business teaching the people the business of medicine. How do you open up that business? How do you? I'm sure there is. It's
a very big disconnect, actually.
Yeah.
Because especially in our line of profession, talking about money and the economic advantages or whatever versus the clinical, empathetic side. The clinician side. It's almost like society and even us doctors, we view it as, oh no, those two things cannot intermingle. Right?
Yeah.
When in reality, let's face it, you take your car somewhere to get the oil changed, they're doing you a service, but they're also telling you this one is going to cost you beforehand. Yeah. So, and they're promoting something else, right? But the problem when it comes to medicine and you trying to do, a good for society is that, well, how much of it is altruistic, how much of it is a service, and how much is the reality of finances, right? So there's not, what you're saying is a very good point. There's not a lot of courses out there that teach you that. There isn't anything that I can tell you, oh yeah, I attended a course on that and this is what I found out. And most you might get a course on, how to build things, okay? How to tell the insurance, this is what you owe me, because that's another problem. Right?
Yeah.
But you don't really have that, okay, those groups and mentorship of, listen, this is how to grow the business side of the medicine, right? It's more of you rely on the goodwill of the person that you did something good on. Okay, so
yeah, of course.
You operate on somebody's, on somebody's dad, and then they send you their son, or whatever it might be, and that's how you build those, more based on ergonomic relationships, if you will, or organic relationships, I should say, rather than massive targeting. Now, the more the field of medicine is more consumer driven, like it is right now, the more we're going to become dependent on things like that, where you're saying marketing, especially for our field. Marketing is something that we have to spend, we have to do, because again, these are people that are coming to you saying, I want surgery, but why are they coming to you? Sure, if you operate in somebody they know, okay. But if somebody's never had any interaction with you, how are they choosing you versus this other surgeon versus this other one who's down the street? What are you basing that off? Yeah,
I was thinking about that earlier before you were going to come. I was thinking to myself, the practice must be based on you do an exceptional job for your patient. That patient lets other people know, and then those people come in. It's got this almost word of mouth, grassroots, but you can't minimize how powerful that is And because I've noticed my best cases come from, without a doubt, from current clients, former clients, and other lawyers that know me, without a doubt. And so, like, you could spend all the money in the world on billboards, but what are you doing to foster and continue that relationship? You know, and even if in the business of medicine, do you have an email system set up, like, or a text message system set up where you're able to kind of just touch them once every couple months, saying, just checking in, seeing how you're doing, give us a call if you need anything. Those things I think can make a big change, you know?
Yeah.
And it's interesting you talk about, like, in medicine, you're drawing that fine line, like you said, of like, you're there to help them, and then there's the business side, and they really can't mix. You know who's gotten really good at that, and I bet like any doctor who's running a practice could learn from, is dentists. I don't know if you've noticed that, but they become brilliant at their business side of things. They've set up a system where they're constantly communicating. They're sending in a message saying, okay, or if they're good at it, right? Mm-hmm. It's time for your cleaning. We'll see you in a month. Here's the date. And they just give you a date or whatever. And then there's a follow-up email. And then when you go in, they meet with you, right? Then they do the x-rays. Then the doctor comes in. Then they give you the buffet. They're like, okay, here's what's wrong. You got this, and this what's wrong. It's going to cost that, and that. But you don't have to do each one. And then it's like, which one do you want? And you're like, oh, man, my teeth are falling apart. You know, like, I got to do at least one. You know what I mean? And they become pros at it. And it has, some of it's become almost like, it is very business. It's almost like the person that you end up sitting down with to talk about the procedure is not the doctor or even the technician who clean your teeth. It's like this other salesperson, you know?
Yeah,
but I think it's a different, obviously it's a very, very different practice. But, you know, you think about just as things progress and grow and, you know, but, and so how do people find you if just as far as, you know, you're located where and which hospital?
So we are part of the Memorial Health System, the Memorial Physician Group. We have a couple different offices in the Broward County area and continue to expand. We have an office in Pembroke Pines, actually only about a mile away from you. I found that out today. And another one in Hollywood, one here in Pembroke Pines, and then another one down south in the Palm Springs North area, where used to be Miami Gardens area. Our phone number where they can reach us at is area code 954-276-1400, or at Instagram at Bariatric Doc.
Bariatric Doc, that's you.
Bariatric Doc.
And do you rotate through the different offices, or like if you have a patient that says, "Hey, I want to meet you over in, let's say, the east side of Broward County"?
So we have different schedules, and we definitely are able to fit patients in and accommodate them, you know, based on their needs. Absolutely. We are privileged in all 5 of the hospitals in Memorial. I also do adolescent weight loss surgery through Joe DiMaggio Hospital. For those individuals that are in need of our services between the ages of essentially 13 and 17.
Yeah. Well, listen, I've been thrilled to have you on the podcast today. I mean, this is a ton of amazing knowledge from an expert in this area, and I think it's just a topic right now that's it's very important for people's health, and it's very popular at this point, and for people's longevity and being healthy, and they should just reach out. I mean, get an assessment if they need to get an assessment, if they're feeling like they're overweight or whatever, come in, meet with the doc, you know, and is at least some of these initial, I guess, different insurance is going to cover different things, right?
Correct. So insurances are a little bit different, but we're always happy to navigate that part of the equation, you know, with patients. That's actually, you know, the most amount of employees that we have in our offices are actually what I like to call the insurance navigators. Okay, the ones that knows the ins and outs of the insurances. If you call us, free of cost, of course, we'll go through the insurance. We'll figure out if your insurance has, if we accept it, if we don't, if you have what they call the benefits for the specific services that you're needing. And most insurances these days are covering things like this. Yeah,
and like an initial consultation too is like, hopefully insurance will cover just that little thing. And then just to meet with the doctor and sit down and get the advice of, these are some of the things, do the assessment, these are some of the things that you can do to change your life.
Correct.
All right, well listen, I appreciate it, man. It's been fantastic.
It's been a pleasure. Thank you.
Awesome.